right, so this is a pressure time graphic, and when the curve goes up, that's just pressure building as the air is being pushed into the lungs. And then on exhalation, the pressure goes down, so it's air coming back out of the lungs. So there's a couple things that it's showing you on here. Again, every time you see this straight line, that's a plateau pressure reading. That means that you pressed the button on the ventilator for plateau pressure or inspiratory hold. All right, on this breath, it tells you that the peak pressure is 28 centimeters of water. And when you push the plateau pressure, you get a reading of 14 centimeters of water. So, and here you have a plateau pressure of 14 centimeters of water. On this breath, peak pressure is higher, and so is the plateau pressure. All right, so what information can we gather from this? All right, so breath number 2, PIP is 28. Breath number 3, the PIP is 36 centimeters of water. So we know that pressure increased. Could the pressure increase be due to airway resistance, or could it be due to stiffness of the alveoli? So the way to answer that question is to know that when the alveoli become stiffer, the plateau pressure reading goes up. All right, from that information, are you able to figure out why the pressures are higher in breath number 3? Very good. So the alveoli got stiffer, and that's what caused the peak pressure to be higher, but also the plateau pressure is higher. It tells you that resistance refers to the pressure created by gas flowing through the endotube and the conducting airways of the lungs. Resistance is affected by the condition of the conducting airways. If they are wide open, airway resistance will be low. That makes sense, right? You even showed me on the board earlier. But if the airways are constricted due to bronchospasm or secretions, the airway resistance will be high. Airway resistance will increase the pressure it takes to deliver volume to the lungs. So this is just repeating the same things that we talked about before lunch. Notice that increased airway resistance causes total pressure to increase, but the plateau pressure stays the same. All right, so breath number 2, we see the peak pressure is 28. And in breath number 3, we see the peak pressure is 36 centimeters of water. What do you think caused the pressure to go up? Was it the stiffness of the alveoli, or was it airway resistance?
Airway resistance.
Very good, it was airway resistance. And how did you know that?
The pressure, the plateau pressure stayed the same.
Very good. Plateau pressure is the same. So we know that the alveoli didn't change, because those pressures, the plateau pressures are the same. But if peak pressure is higher, now we think, all right, maybe they're in bronchospasm, maybe we need to suction the airway. Something's going on in the airway that's making the pressures go higher. Normal airway resistance is 0.6 to 2.4. So write that down, and then I'll give you the units. 0.6 to 2.4. And then it's pressure overflow. So it's centimeters of water per liter per second. So that's normal airway resistance. 0.6 to 2.4 centimeters of water per liter per second. Then, if you intubate somebody, even if you use a size 8 NO tube on an adult, and you measure the airway resistance, it increases tenfold. So write this down. Intubated, airway resistance is 6 to 10, 6 to 10. centimeters of water per liter per second.
And that's normal for intubated.
Yes. So that's normal airway resistance once they're intubated. So that's a huge difference, isn't it?
Mhm.
Just putting a tube into the trachea and having them breathe through a tube, it creates a lot more airway resistance. Name 4 causes of increased airway resistance.
Secretion.
Secretions,
Bronchospasm.
bronchospasm,
Narrowing.
like a small endotube.
Like inflammation.
Okay, so let's put bronchospasm and inflammation together.
Small ET tube,
Small ET tube
a fast flow of air.
and a fast flow rate. Okay. So to calculate resistance, it's peak pressure minus the plateau pressure. So peak pressure is pressure at the airway opening. Plateau pressure is measuring pressure in the alveoli. So do you remember what that's called when you have a pressure gradient from at the endotube to the alveoli?
Trans-airway.
Trans-airway pressure, all right, very good. So that's what that PTA is afterward. Trans-airway pressure divided by the flow rate will tell you your airway resistance. So I'll give you some numbers to plug in. After you plug them in and you get a value, the next thing that you do is multiply your number by 60. And what that does is it converts liter per minute to liters per second. All right, so here we go. Patient on a ventilator has the following values. The peak airway pressure is 58 centimeters of water. The plateau pressure is 40 centimeters of water. The flow rate of gas is 40 liters a minute, and it wants you to calculate the airway resistance. So pressure on the top, flow on the bottom. Pressure over flow. You got 27?
Like 45.
27.
It was 18 over 40, right?
27.
Yeah.
And then you multiply by 60?
Yeah. 27 centimeters of water per liter per second.
Excellent, very good. All right, everybody's got that?
What is the units?
Pressure overflow, so centimeters of water per liter per second. You multiplied by 60, right?
Yeah.
Yeah, liters per second. All right, I have a question for you. If a patient bites down on their endotracheal tube, will plateau pressure increase?
No. It would stay the same.
All right, so plateau pressure would stay the same. Would peak pressure increase?
Yes.
Yes. So when the air is trying to go through an endotube that's now kinked because they're biting on it, it's going to take a lot more pressure to get the air past that kinked area in the endotube. So pressure will be higher. But when you do an inspiratory hold or a plateau pressure, that number is going to be the same because that just reflects the pressure in the alveoli. All right, do you need to write that down or will you remember it? You okay? And again, D2L has more practice questions for you. All right, a patient on a ventilator was generating pressures of 25 centimeters of water during peak inspiration. Now, the pressures at peak inspiration are 30 centimeters of water. Is the increased pressure caused by an increase in airway resistance or a decrease in lung compliance? So it tells you initial patient values, peak pressure, 25 centimeters of water, static pressure or plateau pressure, 20 centimeters of water. And then 2 hours later, peak pressure is 30, static pressure is 25. So is that from an increase in airway resistance or a decrease in lung compliance? Yeah. So when the alveoli get stiff, it's called lung compliance. Just want to make that connection for you. So yes, very good. The pressure went up, but you notice that the static pressure went up also. So that just tells you that the alveoli are getting stiffer, or the lung compliance is getting stiffer. Any questions on that?
So if it stays the same, it would be due to the airway,
Yes.
always?
Yes, always. So static the static pressure stays the same, but pressures went up, it's always going to be because of airway resistance.
Okay.
So the static pressure is the same thing with the plateau?
Yes, so yeah, static pressure, plateau pressure, same thing. All right, so that's it for airway resistance, dynamic compliance, and static compliance. We're going to move on to some other terminology. The next one talks about elasticity. And that's the tendency of a structure to return to its original form, or the ability to recoil. A patient with high compliance has a decreased ability to recoil. They have low elastic recoil. Does that make sense from what I described earlier? The patients with COPD have lost the elasticity in their lungs, and now they can get the air in, but when they try to get the air out, it's hard to get it back out again because the airways are not supported open. They kind of collapse, and the air gets stuck. So low elastic recoil. And then along with low compliance, really stiff lungs has an increased ability to recoil. So it would be like taking something really hard, you finally pull it apart. When you let go, it's going to snap back into place. So stiff lungs have a high recoil. You can get them open finally with a lot of pressure, but then they recoil very quickly. So high recoil with low lung compliance, and then the opposite with high lung compliance. Do you need to write any notes to clarify that, or does it make sense? This is going to tie into when we're putting settings on the ventilator, and you put air into the lungs. How long do you have to leave for the air to come back out again? So this is kind of a lead into that. What is a time constant? It is the length of time required for the lungs to inflate or deflate to a certain amount or percentage of the full volume. So if it takes, 1 second to put in half the volume, that would be considered a time constant. Oh, it took 1 second to get the air in. That's a time constant. This is important when setting the ventilator for the amount of time for the tidal volume to be delivered, or for allowing enough time for exhalation. So when you're putting a volume of air into a patient's lungs, you can put it in real slow, or you can put it in fast, or you can put it in between. And when they exhale, it could take a little bit of time, it could take a lot of time. That's where we're going with this information. All right, it wants you to calculate a time constant. And the way you do that is you multiply the static compliance value by the airway resistance value. And that's going to give you a time constant. Calculate the time constant for a patient who is intubated on a ventilator and has normal lung values. So their static compliance is 50 cc's per centimeter of water, but notice that that value is in liters. Do you know how to get from 50 cc's to liters? Yeah, you move your decimal point 3 places to the left. So it's 1, 2, 3. So this needed a 0. So 0.05 liters is the same thing as 50 cc's. And remember, 50 cc's is normal static compliance. All right, so that's normal. Airway resistance, it says 8 centimeters of water per liter per second. And we said 6 to 10?
Yes.
Okay, so that's normal. So when you multiply the two, you come up with 0.4 seconds. Do you see how the liters cancel themselves? Centimeters of water cancel themselves, and you're left with units of seconds. So 0.4 seconds is the time it would take for a lung to fill with 63% of its full volume. Why 63%? I have no idea. That's what the textbook said. It said that one-time constant is how long it takes for 63% of the lung volume to fill or to empty. Two-time constants, so 0.4 seconds plus 0.4 seconds would be two-time constants. That's how long it would take for 86% of the lung volume to fill or to empty. Three-time constants would be 0.4 plus 0.4 plus 0.4. That's how long it would take to get 95% of the volume into the lungs. And then 4-time constants, you go from 95 to 98% to get the lungs full of air. Let's figure out how long it takes to get 98% of the full volume into the following lung. Are you ready for this? It tells us the static compliance is 30 cc's per centimeter of water. It's a little stiff, isn't it? Airway resistance, 10 centimeters of water per liter per second. That's normal. 6 to 10, it's on the high side. All right, so what's the first thing you have to do?
Multiply 30 by 30
So we need to change the, from milliliters to liters.
Yeah, first thing you need to do is to get the compliance reading from cc's to liters. So the first thing you do is move your decimal place 3 to the right. So 1, 2, and then stick a 0 here. 0.030 liters per centimeter of water, so that's the first thing. And then the second thing is you just multiply the two numbers. When you multiply 0.03 times 10, you get 0.3. So it takes 0.3 seconds for one-time constant. But now we have to multiply by the number of time constants for 98% of volume to enter the lungs. Multiply by 4. Very good. 4 times 0.3? 1.2 seconds. And for somebody that has relatively normal lungs, that's what it takes to get their tidal volume into their lungs. About 1.2 seconds.
Then no more ready for
Yes. Kind of normal. So 1, 2, 3, 4.
So you can give us a problem saying like, to figure out how long it would take for, I guess, what is it, like 98%, and we have to know that it's the 4 time constants.
Yeah, so on the exam, I'll tell you, figure out like 95% to go in. This is 3 time constants.
Okay, so we
So
don't
that's
have
one
to-
less thing you'd have to memorize. Yeah. Yeah, I'll mention that on the exam. So calculate the time constant for a lung that is very stiff. The static compliance, 15 cc's per centimeter of water. Airway resistance is normal though, 6 centimeters of water per liter per second. So what's the first thing you do? Convert to liters. And what do you get?
0.015 times 6.
Okay, so 0.015 times 6. It's 0.09? Wow, okay. It's pretty short. All right, so 0.09 seconds. Calculate the time constant for a lung that is very compliant. The static compliance is 60 cc's per centimeter of water, and airway resistance is normal.
3.6 seconds.
Are you sure?
0.36.
Should be 0.36, right? All right, so 0.3 seconds for that one. Which lung would fill and empty more slowly? Yeah, the one that's going to be more slowly is the one with the higher seconds for time constants.
The lung that's very compliant.
All right, so you calculated a time constant for the stiff lung that was 15 cc's per centimeter of water. And you came out with 0.09, is that right?
Yeah.
So if that's the time constant, how long is it going to take to fill that lung up with air? You just multiply that number by 4. Okay, what did you get for the compliant lung with a static compliance of 60? And then multiply by 4 to find out how long it takes to fill the lung?
1.1.
All right, so the stiff lung is easy to, it doesn't take long for the air to go in and then come back out again. Again, it's really highly elastic, so it empties quickly. This is the stretchy lung. You can get the air in, but to get it back out, it's going to take a long time. All right, so that's pretty much it. Okay, another term, we've got like a little bit longer to go, so bear with us. When you put a volume of air into the lungs, some of the air stays in the conducting airways, stays in the trachea, the bronchi, the bronchioles, And the rest of the volume of air that you put in will actually make it to the alveoli for gas exchange. So the air that's in the conducting airways, because there's no alveoli in the conducting airways, it's considered dead space. Again, it's a weird name, but that's what it's called. The conducting airways, it's called anatomic dead space, and you can figure out how much dead space you have in your lungs by multiplying 1 by your ideal body weight. So if you're 150 pounds ideal body weight and you multiply by 1, you get 150 mLs of dead space. So your trachea, bronchi, bronchioles occupy or will hold about 150 cc's of air. If 150 cc's of air does not exchange oxygen with the alveoli. So the next question, if you put in a 500 ml tidal volume, what percentage is dead space? So you just divide the two. The dead space, divide by the tidal volume, and it gives you a percentage. Are you okay with that? Does that seem straightforward? Probably getting saturated by now, right? There can be alveolar dead space, and that would be alveoli that don't have blood flow coming to them. And then the alveoli become just like our conducting airways and become dead space. And you can combine the two. Alveoli that are not functional because there's no blood flow, plus the conducting airways, the two of those together, it's called physiologic dead space. That's anatomic and alveolar dead space. And what notes did I want to give you on that?
Okay, so the third one is just a combination of the first two?
Yes.
I have a question.
Okay.
Anatomically speaking, would you find these alveoli towards the boundary of the respiratory zone or further towards the end?
Alveoli?
Yeah, would you find them more near like the conducting airways, the alveoli that's closer to the boundary where the conducting ends and the respiratory zone begins?
Yeah, so the respiratory zone always begins at the end of the conducting airways.
Right. Well, but if you find alveoli that are in dead space, would you find them near that boundary?
No, that would be low blood flow or a blood clot, like a pulmonary embolus, stopping the blood flow to go into that sinus.
PE.
Mm-hmm. So what I need you to write down is 30% or less is a normal ratio. And 50% and higher is abnormal.
Okay.
50% and higher is abnormal.
30% is normal.
Yes. All right, so let's apply that information a little bit so you get an understanding of the importance. Pardon me. A 5-foot person has an ideal body weight of 100 pounds. What is the anatomic dead space for this person?
100 cc's.
Yeah, 100 mLs. The weight times 1, so 100 times 1 is 100. So the dead space is 100 mLs. If the person's tidal volume is 150 mLs, is their alveolar gas exchange normal? So 100 over 150, 66%?
It's 0.66.
That's abnormal. So what that pretty much tells you is that their tidal volume is too small, and you're not getting enough air going to the alveoli for gas exchange. So it's kind of like a little physiology to go with when you're at the bedside and you're trying to wean a patient off of the ventilator, you pay attention to the tidal volume that they can move on their own. If their tidal volume is really small, then you know they're not going to do well if you take a tube out and let them breathe on their own, because their tidal volume needs to be a little bit bigger in order for that air to get to the alveoli and actually participate in gas exchange. So that's the bottom line. Just make sure they have a good tidal volume before you extubate them. But these PowerPoint slides are just giving you that background physiology. That tidal volume needs to be big enough so that enough of it's going to the alveoli. Yes.
The ideal body weight, is that calculated or is that the real weight?
Ideal body weight goes off of the height of a person.
Okay, so like BMI.
Yeah. Now, I think next week we work with ideal body weight. I'll give you the formula to calculate it. So does shallow breathing, like smaller than normal tidal volumes, compromise good gas exchange?
Yes.
Why? Or is it too obvious and seems difficult? It's because you have less air going to the alveoli. It's all staying in the conducting airways and just moving in and out of the conducting airways. The breath needs to be large enough so that some of it's going to the alveoli.
So,
Go ahead, it's okay.
No, I didn't read the compromise. I just saw good gas exchange.
yeah, that's
So
what
it wouldn't be good gas exchange.
Yeah, compromise means bad.
that's what I thought too in my head.
Oh, you did,
I
really?
skipped over compromise.
Yes.
Yes, it does compromise good gas exchange. All right, a critical thinking question. Patient A has normal conducting airways. Patient B breathes through a tracheostomy tube. The patients have identical breathing rates and tidal volumes and are of similar height and weight. Comparing these two patients, alveolar ventilation is, all right, let's see. So normal conducting airways, they're breathing through their mouth, right? They're not intubated, they don't have a tube in. And B has a tracheostomy tube. So there's no oropharyngeal dead space at all. The air is just going right into the trachea. So, same tidal volume, which one would have more air going to the alveoli?
Patient B.
Yes. So the answer is A.